In this video, we are going to talk all about pain science and some of the myths surrounding pain science and beliefs around pain science and all the things that people are afraid of doing. This goes into health anxiety, health OCD, fear of injury. I'm going to not really touch too much on fear of death, the kind of the severe stuff, cancers, triple A's, heart attacks, aneurysms, all that. No, I'm going to stay primarily in the pain belief systems and where so much of the community in the mental health community, I'm so used to saying that, in the medical community, get this incorrect. They miss this massive thing. So before I go any further, please subscribe, hit that like button down below. This will be a great video for some of you nerdy scientific people. I will use a little bit more, I don't like using the word advanced, but I'll use lingo that's more in tune with the medical community. And Phil at OCDrecovery.com. Please let me know what you think. If you're suffering with this, please reach out. Okay, so and what we have is called the evidence-based triad. There are three components, and it doesn't work in thirds. It's a little bit different depending on the scenario. And you'll never know how much you have to apply, but a lot of people do not get one of them. Number one is the evidence, the empirical data, the statistics, which, by the way, stats in data when it comes to mental health and pain perception is wishy-washy at best. Why? Because anyone will say anything when they're triggered. So, and they skew those things. So those things are off the chart. Number two is the provider, whether it's a medical doctor, a chiro, physical therapist, massage therapist, acupuncturist, a mental health provider, psychologist, psychiatrist, social health worker, anything. Their personal anecdotes, what they see, expert hours, having a condition, coming out the other side, maybe not having the condition, but still being very educated, working in that particular category, okay? I personally believe in order to be very good at something, you have to work with that specific thing over and over and over and over and over again for long, long periods of time. And third is what we call in the medical community the patient preference, their belief systems, what they want out of what they're doing, treatment, care, whatever you want to call it. The way people view their conditions is largely overlooked to the nth degree. Even in places where I would say the medical system might be a little bit more up to date, maybe America, the UK, other areas of Europe. If you go to Eastern Europe, I work with people all over the world. Depending on where you live, I work with people all over Eastern Europe, and the medical community can be a little bit in the dark ages in certain things. It's just the way the world works. Certain areas in the Middle East, not so much in Dubai or maybe Saudi Arabia, but different places will have different belief systems in communities, in the medical community, on how to treat certain things. AKA, there's certain places in Eastern Europe where benzodiazepines are still pushed like Skittles. And that is a big, big problem. So the way you view your condition will have large outcome assessment issues when you're dealing with a disc herniation, a sprain, strain injury, strain ST muscle, sprain SP ligament, a burn, an autoimmune condition, all that type of stuff. Anything ranging from Crohn's, colitis, IBS symptoms, migraines, hormonal issues. And and we're not saying, I'm not here to talk about the biological origin of something today. I'm not talking about the physiological origination, okay? The genetics. That's not what I'm here to talk about. I'm here to talk about your view on that thing. Let's use some basic examples. I'm going to pull out the sticky notes. I'm going to take that sticky note off my desk because I have a bunch of my stuff written down. Okay, so person one has a disc herniation, okay? If you don't know what that is, what can I use? Oh, here we go. Okay, just imagine that this is a disc, okay? A disc in your back. And this is called the annulus fibrosus. Okay, we're going to learn some stuff, okay? Inside is called the nucleus pulposus. Okay, there's all sorts of things in here. That looks funny. There's all sorts of things in here that don't really need to be outside of this. Okay, one of them is called tumor necrosis factor. That doesn't even sound good. And when that cracks through, the annulus fibrosis and goes out, it causes a whole host of problems. But then that's acute disc herniations, but then you have subacute and chronic disc problems where there's fibrotic scarring around the nerve sheath. So it's not as simple as like, this is a disc herniation, this is the treatment, this is what they have to do every single time. You have to understand the age of the person. The chances are there's arthritic changes. Someone blows a disc out, golfing, and flexion and rotation in an acute setting. The chance of there being arthritic issues that could be compressing the nerve sheath, not probable. Not probable at all. Symptoms can be the same, but it's important to know so you can know how to treat the person, okay? I know I'm going a little bit more in depth, but I think it's important for people to know this to see how much incorrect information is out there. So person 1, okay? And then you have person 2. Okay. Both of them have a lumbar disc herniation. I'm going to just write LDH for short. Lumbar is your low back, okay? Most people do have 5 lumbar vertebrae. Every once in a while, there's a 6th. Just like the neck, 7 cervical vertebrae. Sometimes there's an 8th. Whoa. And then people have missing ribs sometimes, etc. So the scale, we use these pain scales. 0 to 10. Okay. So both of them have we can't prove it, but let's say in a nerve conduction test, okay, and an EDX test, we stick a needle in the nerve and we shock it and we test the function of the nerve. So we're going to say the lumbar plexus, the sacral plexus, which goes out and then forms the sciatic nerve. Well, not exactly, but just imagine lumbar nerves 4, 5, S1, 2, 3. Those come together and form the sciatic nerve. I'm 99% positive those are the nerve roots that form the sciatic nerve. Anyway, so when that happens, we could test it. We would know, okay, this person has a 5 out of 5. Okay. We don't need to know this, but I'm just using it for the example that I'm giving. Person 1 is very pessimistic, very negative, and has what we call passive coping, aka avoidance behaviors. There's a good chance they're going to experience an 8. And they feel that. That's not made up in the sense of they feel an 8 out of 10 in their body. They really feel it. And you cannot prove your way out. You really feel an 8 out of 10. But let's say person 2 has a better perception, applies ACT, acceptance commitment, cognitive behavioral therapy, RBT principles, unconditional self-life, other acceptance, has active coping capabilities. They go out there, they rehab it. Maybe they feel a 3. Now, again, this is a very basic example. That right there happens all the time. All the time. See it every fucking day. Every day of my life. In the chiro field, in the medical field, all sorts of stuff. Now, let's talk about behaviors. Ooh. We're really going to go down the rabbit hole in this one. Because this one used to be it is still a pet peeve of mine, but it doesn't bother me anymore. Milo's barking. What is he barking at? So, behaviors. Passive coping. Not wanting to do anything. There's nothing wrong with any modality. They all have to serve a different purpose. Chiro, massage, physio, rehab, dry needling, all sorts of stuff. Surgery, injections. But we need to understand that if you're only, I'm going to talk louder so you can't hear the dogs barking. If you're only using passive coping, you're doomed. You're fucking doomed. There's no other way around it. I've seen people, you could still do active care if you lose your legs. I've seen it. I've seen crazy stuff. Someone hiked Everest with no legs. Don't recommend it. I know it's a large example. It's an outlier on the spectrum, but it still matters in the sense of the way you go against this. Okay, if you blow a disc out or if you strain, the people with the best outcomes are the people that go into it and rehab it. Now, for us, we have to be careful with the compulsiveness and the Google and all that stuff. I'm just giving you a basic outline. This is a pain science video. It's not so much in the strict sense of don't do these particular things when there's an obsessive compulsive cycle or a PTSD cycle, et cetera, because it all relates together, okay? Someone can have severe PTSD from being in a motor vehicle accident where they lost a best friend. If they never get in the car again, which is passive coping, they're going to have really bad symptoms and really bad belief systems. And we're going to go into the belief systems last. So the behaviors. These are the ones that matter the most, okay? Rehab. Oh, no. No, I really like this pen. That's sad. Okay, here's another one. Rehab, aka exercise. Okay, that's a really big one. This is a behavior. Okay, so decreasing venting, like venting is a behavioral action. You're behaviorally venting, which then comes with poor coping mechanisms, avoiding things. So decreasing venting, decreasing avoidance. Again, this is all within reason, of course. We understand if you break your arm, I don't want you curling a bicep, 30-pound dumbbell, the next day. This is within reason. Use some common sense here, individuals. So, but the more you go towards this in a behavioral sense, in a balanced way, the better outcomes you're going to have more than likely. Now, let's talk about beliefs. I'll show the belief one to the screen afterwards. There are catastrophic beliefs that are perpetuating the experience of pain. There's no doubt about that at all. Okay? Let's use some basics. I hate pain. Pain ruins my life. Again, this is whether you have pain there or not. Whether you have pain there or not. Just like any other symptom. I hate pain. Pain ruins my life. If only I didn't have this, my life, this is exactly what people say, my life would be perfect. These are just three of many. Okay? I hate pain. Pain ruins my life. If only I didn't have this, my life would be perfect. That right there, those beliefs, combined with how they view their pain, combined with bad behaviors, equals a life of suffering. Suffering is a human experience. It does not necessarily mean the absence, that their symptoms need to be there. People suffer for a multitude of different reasons. Their belief systems, you can have negative emotions. You can have pain, depression sensations, shame and guilt, and not suffer because of your belief systems. You might have discomfort, but you don't view that anymore as suffering. You view it as annoying and very inconvenient. And your life would be much better, more than likely, if it wasn't present. But you gotta work with what you have. This is critical. Don't want to go too much more in depth because it's not a science-based channel, but it is really cool for people to hear this. And I'll leave you with some ending fun facts. What do we think is going on? So we have what's called the BPS, which is the biopsychosocial model of care. And then we have, which I talked about, NSS, nociceptive system sensitization. It's a tongue twister. Okay, real quick. I'm going to draw, we're going to say this is a brain. This is a brain stem. Your spine. Okay, we're just going to say for fun, these are all the nerves, okay? So, brain stem, okay, central nervous system, peripheral nervous system goes down, stuff like that. You can look it up if you think it's cool. Just go to Google and type in central nervous system, peripheral nervous system. Somewhere in here has become sensitized. It could be a singular tract. It could be one portion, okay? It could be the entire peripheral nervous system. It could be the central nervous system. We don't really understand. Anyone who tells you that we do is not being honest. It's too complex. The research is moving in the right direction. But the last time I checked and the last time I look at this, because it's important for my continuing education, it's not what people think. You cannot pinpoint it. We don't know what's going on. We just know that there's a sensitization somewhere in the tract, a singular part, multiple parts, gapping in parts, we don't know. In the thalamus, somewhere in the brain and other areas of receptor signals, something is sensitized, and that is causing a whole bunch of problems, which then causes pain, real physiological pain, which causes belief systems, etc. So this is what we think is going on. Thank you for watching. Phil at OCDrecovery.com. Let me know what you think. Hope to hear from you soon, and enjoy the rest of your day. Always a pleasure, guys and ladies.